Can you differentiate the difference? You're using, I think, specific language, mold toxicity versus mold exposure, mold allergy. Can you parse those differences? Because a lot of people that I have seen in my clinical practice, as well as others I've talked to, are told there's a mold allergy problem, but if you're not allergic to mold, then if you don't have the coughing, the sneezing, the wheezing, that type of symptom profile, then you probably don't have mold exposure. But could you parse those differences?
Yeah, sure. So in medicine, we've known about mold allergy forever. That's not a new concept. We've known that a rare patient will get a mold infection, which is a kind of a life-threatening illness which requires antibiotics. That's rare, and that's not what we're talking about. We're talking about the fact that molds make mycotoxins, which are mold toxins, and those mycotoxins will affect the body by creating a generalized inflammatory condition. And so this is not mold allergy, although they can coexist. You can be both allergic and toxic to the mold. So mold toxicity is a kind of it's not a new concept. It's written about in the Bible, but it's not been appreciated in the medical field until now. And even now, it's still not really known much about it or understood.
Why do you think that is? I mean, what is there a lack of formal training in medicine? Is it just people don't want to wake up and see that, that mold might be more prevalent and we actually have to do something about it, even beyond medicine, like with construction and building and other.
Those are two separate areas of denial. There's denial on the part of the building industry, where it's estimated by many experts that up to 50% of all homes in this country have an appreciable amount of mold in them. So this is not a rare experience here in this country or anywhere. Um, but there's denial on the part of the medical profession. And what I've experienced, Peter, is medicine is very quick to embrace new medications and new technology. That's because there's a huge economic driving force behind it. Medicine is really slow, and the history of medicine, history of science, is that new concepts are not embraced immediately. There's this kind of reluctance, which is, well, you're going to have to prove it. I need to see enough written in peer-reviewed medical journals. I need to have proof of science before I take my precious time and study something that I never heard of before. And that's gone on forever. Any new concept in medicine takes a while for our profession to embrace it. It just does. Maybe that's a fail-safe. Maybe that's good, and that we don't embrace every cockamamie new concept that comes down the pike. On the other hand, um, some of us have been in this field for 20, 30 years, and I've personally helped 4,000 or 5,000 people get well from mold toxicity. So in my world, this is not a new concept. This is very real. This is what I help people with all day long. And it's frustrating for me and for my patients to not have the field embrace it. So if you go to most physicians as a patient and you present with these complex symptoms that cover the whole highway, it's more likely than not that someone will either honestly tell you, I don't know what's going on here, or they'll refer you to a specialist for a piece of it. So if you have joint pain, muscle pain, which is common in mold toxicity, you might see a rheumatologist. You might see a pulmonologist for the respiratory issues. You might see a cardiologist for the cardiovascular issues, or a neurologist. And so it's that classical story of the blind man and the elephant, where in a specialist field, each sees a little piece of it. And not a lot of people are putting it together as asking the question of, okay, what physiologically could cause anyone to have that many symptoms? And the simple answer is inflammation. And I think as a field, medicine is beginning to embrace inflammation as an underlying component of almost all chronic illness, but just beginning. I mean, and there are peer-reviewed papers that have been out for the last 6, 7 years, where that's literally the title of the paper, Inflammation as a Cause of Almost All Chronic Illness, written by academics, peer-reviewed, but that information isn't trickling into the people on the front lines.
What would your advice be to a patient who maybe suspects they're in mold? What kind of doctor should they seek out? Is there a particular, postgraduate training or a website, a database that they could go to find a mold literate doctor?
It's difficult. There's no certification process for a field that medicine doesn't quite recognize yet. That's down the road. Um, I have on my website um, a listing of physicians that I've trained. So people all over the country and world um, certainly are listed there. So patients can go to my website, which is just neilnathanmd.com, and look for medical practitioners. People I've worked with enough that I know that they know what they're doing. As a general concept, physicians who specialize in integrative medicine or functional medicine are the kinds of physicians you would want to work with. But not all integrative or functional doctors are familiar with mold toxicity per se. So that's a starting point, but you need to find someone who actually has some experience in this field because it's complicated. When people do have mold toxicity, it's not a simple treatment where here, take this for a week and you'll be well. This typically takes a year or more of complicated treatment to get people well. But my take-home message, which I really want to leave people with, is it is treatable. We can get the vast majority of the people we work with well.
What what types of tools are you using clinically with your patients to help understand whether or not they're in mold? As you've mentioned, inflammation is a driver for a lot of conditions, and there's a lot of reasons people might have inflammation, but are there specific biomarkers or tests that give you greater insight or help you rule in or out mold?
I think the best test, most specific test, is a urine mycotoxin test, which very simply, a patient collects their first morning urine and it goes off to the lab and be analyzed for the presence of mycotoxins. Uh, if there are mycotoxins in your urine, it's in your body. It's coming from somewhere. So that is, for me, the most simple, easy, direct way to know that there are mycotoxins in the body. And I then know which mycotoxins are in that body because we do use binders to get mycotoxins out of the body, and the different mycotoxins are bound differently. So, for example, if you had ochratoxin in your body, which is a common one, then cholestyramine, Welchol, which are both medications, or activated charcoal are the best binders for that. And down the line, each mycotoxin has specific binders that will help pull it out of the body. So that's urine mycotoxin testing to answer that question is, for me, the number one test to do. There are some biomarkers, but they're not as specific as we need them to be for mold. For example, when people talk inflammation in medicine, that generally means we check a SED rate or a C-reactive protein. Those are the most common tests we use. That won't show up mold toxicity. For whatever reason, the kind of inflammation that's triggered isn't reflected in those tests. So again, if a patient goes to a physician and they've got joint pain and muscle pain and they say, I'm inflamed, and they check those tests, they'll come back, well, no, you're not inflamed because those tests are normal. Not the right tests. So other tests have been discovered. Dr. Shoemaker uses TGF beta 1, C4A, and MMP9 as three tests which really will reflect the presence of mold toxicity. However, it will reflect the toxicity or inflammation of Lyme disease and several other inflammatory materials. So it's not specific for mold, but if it comes back high, it will certainly raise the suspicion of, okay, what's making that TGF beta 1 go up to that extent? It's a real condition. We're not talking psychological here. Something is driving that. And then you need to still go back to the drawing board and get a urine test to go, okay, is it urine or do I need to do a Lyme test to figure out is it Lyme disease? But those markers are helpful. Most recently, I've gotten excited about Bruce Patterson's Radiance Lab, which measures 14 different cytokines in the body as a cytokine panel. And he's discovering that there's a different inflammatory cytokine pattern for long haul COVID and for Lyme disease. So you literally can tell, okay, this pattern reflects long haul COVID, and we can treat that. This reflects Lyme disease. And we've just started working on mold, and there is a different pattern for mold. So although we're just in the beginning phases of doing that research and getting it published, but we are, I think, shortly, that test will be a great way to be able to tell what kind of inflammation is going on. And we can then narrow our focus on, okay, this is most likely to be mold with this pattern, or this is more likely to be Lyme with this pattern. So we have some markers, but they're helpful in letting patients know it's not in your head. This is real. But you kind of need to know that the markers are not as specific as we need them to be.
So in your opinion, then mycotoxin is the most direct evidence of exposure, and then inflammatory markers, non-specific, but clues, breadcrumbs to the road of, potential mold.
Yeah,